Welcome to my investigation on current and emerging medical AI. Before we get into the video, let's talk about the what and the why. This video will be an overview of my comparative case study of medical AI, where I was able to categorize medical AI into 4 groups and explore its bottlenecks and potential. I want to study this because AI is a rapidly expanding domain that will soon integrate into the majority of modern society. The purpose of this video is to prepare and inform others of changes to come in this developing field. Now let's get right into it. Medical AI can be simplified to 4 applications: scan analysis, data compilation, AI-robot integration, and epidemic prediction. Before we go in depth on each particular subsection, it's good to have a base understanding of AI itself and how the different types of AI contribute to each subsection's capabilities. So let's break this down starting from the big picture. You have machine learning, or ML, and it's basically the broader field of AI where computers learn from data the same way we learn from experience. The system looks at patterns, learns from mistakes, and gradually gets better at tasks. These tasks are things like recognizing trends, answering questions, and even generating text. It's the foundation behind all the generative models we use today, including tools like ChatGPT. Now, within machine learning, we have deep learning, or DL. DL is a more advanced subset of ML that will learn progressively higher features from even larger datasets. It's especially powerful for things like data compilation, which we'll talk about later. And then we can get even more specialized with convolutional neural networks, or CNNs. CNNs are a specific type of deep learning model designed to handle grid-like data structures, which makes them perfect for images. They operate in a similar way to how we visually process the world, by scanning an image, picking out features, and piecing together what's going on. Technically, it's based off the human mind and designed after it. CNNs will be used in tasks like medical scan analysis, image recognition, or anything that requires interpreting visual information. We'll talk about this some more when we talk about scan analysis. And finally, we get to NLP, natural language processing. NLP is another AI subfield that relies heavily on deep learning, but instead of images, it focuses on human language. NLP models analyze text from sources like news articles, reports, or social media to understand the meaning, detect patterns, or even identify early warning signs for things like health trends or misinformation. Essentially, NLP lets machines read, interpret, and respond to language in a way that feels natural, and it's especially vital in epidemic prediction. Now that we have a base understanding of AI, let's start with scan analysis. Scan analysis medical AI is where the model will analyze X-rays, MRIs, CT scans, and more for harmful irregularities. It typically uses CNNs, which, as you remember, mimic the human brain, and it will either provide assistance to physicians or fully read and search for abnormalities itself. It's been proven to be helpful in increased accuracy in dermatology and oncology. In dermatology, it's known for tumor detection, seeing whether a tumor is benign or malignant, and its ability to analyze chemical compounds and biological targets from scans. This former ability optimizes efficiency and safety because the doctor is then able to identify the best possible drug to administer. In oncology, medical AI is proven to improve lung cancer nodule characterization and reconstruct CT scans. AI nodule characterization extends to figuring out size, volume, density, and malignancy of nodules. Their scan reconstruction recreates the image with lower radiation while still keeping the image quality and acting as a second reader to catch any missed signs the physician forgot, as well as improving the image to make it easier for physicians to read. These capabilities can also be applied to pathological tissue samples, and overall, it will act as a second reader for physicians and has shown to improve accuracy and efficiency. Next, let's talk about data compilation. Data compilation is basically how AI uses massive amounts of information to make smarter decisions. This is where DL really shines, because it can handle those huge data sets that would overwhelm any human. These DL models are able to integrate data sets of electronic medical records, live variables, and treatment plans to predict perioperative risk by running in the background as a checklist. By running on the background as a checklist, it's able to keep an eye on all the patients with a list of warning signs, and if multiple warning signs are flagged, it's able to call a nurse to check on the patient. It improves patient care and likelihood of acute injury detection by always having somebody watching over the patients and taking care of their health. A real-life example is inside the ER at SU's hospital, where an AI was used experimentally in the background to keep an eye out for sepsis. Sepsis is an overreaction to inflammation with a 30 to 40% fatality rate. In this case study, the AI monitored over 150 different potential signs of sepsis and alerted a nurse when multiple indicators lined up. Results showed about a 17% reduction in mortality, which is a huge for a condition that's notoriously hard to catch early. Since sepsis is easy to miss without actively searching for it, having an automated system acting as a second pair of eyes increases the chance of early detection and ultimately improves patient care. Next is AI robot-assisted surgery, and it's transforming how doctors operate. It's how it sounds. The typical robotic surgery that hasn't yet been able to progress into real implementation is integrated with an AI system to help it adapt and make more human-like decisions. Mostly within orthopedics, its usage has shown to not be about replacing surgeons, but improving precision, planning, and consistency in the operating room as a tool. Let's look at how it's being used in hip and knee replacements. Starting with total hip arthroplasty, or THA, one of the main systems used is called RoboDoc. It's featured on the side. RoboDoc helps surgeons plan where to place implantations and uses robotic tools to mill the bone with high accuracy. Milling is essentially where the AI is able to use a drill to shape the bone canal in the most accurate way to fit the implantation and the person's unique skeletal structure. This precision is able to reduce complications during surgery and ease recovery afterwards. However, it's also shown to make the procedure take longer and increase blood loss. Next, there's unicompartmental knee arthroplasty, or UKA, which is a partial knee replacement. Systems like Mako and Navio will assist surgeons by planning and balancing soft tissues for smoothest post-op recovery. They rely mostly on CT scans and digital mapping to guide each step, and these systems are able to improve alignment and precision, but there are concerns being raised about the higher costs in hospitals and the hospital relationship with relying on external companies. Outside of that, in research and development, robotic surgery is moving towards greater customization. Robots can make complex three-dimensional cuts and make implants and fit implants to each person's unique anatomy. It's proven to improve revision surgeries and create implants that match each body more naturally. Overall, it's enhancing precision, planning, and personalization, not replacing surgeons, but upgrading tools to make surgery more safer, accurate, and suited towards each patient. Lastly, AI is also being used to predict and manage disease outbreaks through something called augmented forecasting models. These models were able to predict daily COVID-19 deaths, cases, and hospitalizations for up to 4 weeks in advance and have been tested in both the United States and Japan. What makes them impressive is their ability to adapt to major changes, like new variants or shifting government policies, even when human behavior and demographics are differing between two countries like Japan and the USA. One example is Pandemic LLM, an AI model that outperforms traditional forecasting systems like CDC's COVID Hub. It uses real-time data to identify patterns in disease spread and hospital demand. Its framework combines three things: cross-data source fusion with NLP, outbreak forecasting and decision support, and it aligns itself with public policy, governance, and ethics, creating realistic solutions. It helps protect public health by responding to viruses faster than ever, showing how data and language models can be used to predict and respond to pandemics more accurately than ever before. However, there are still barriers hindering AI's further development. To start, we have ethics. Some of the few problems are the black box of AI, patient privacy, racial and ethnic data bias, and harmful integration. To start, the black box of AI refers to the idea that the internal workings of an AI system, especially complex ones like DL models, are not easily understood or interpretable by humans. In other words, while we can see the inputs and outputs of the system, how it arrived at a specific decision or prediction is often opaque or unclear. This is a large barrier for medical AI because physicians and patients require the utmost transparency in their care and treatment in order to trust the AI outcome. Next, we have patient privacy. And this leads to the same black box of AI problem, where we aren't aware of what goes on behind the scenes in the relationship between the data we're inputting into the AI and the parent company that the AI works with. Next, you have data, racial, and ethnic bias. Bias in AI can sneak in at almost any stage. Even if an algorithm doesn't explicitly use race, it can still make unfair decisions. This is because the data is often trained on real-world inequities. Things like the AI being tested on a majority of white or Western populations could lead to misdiagnosis in other communities. This means that the people who are already marginalized could get the wrong treatment or, even worse, not get treated at all. It can come from a number of places. Like we mentioned before, the data. Sometimes certain groups are underrepresented or important factors like social conditions aren't included. There's also how the AI is built and tested. If developers only focus on accuracy, they may miss that the model works worse for some other populations. And then how it's actually used in hospitals with real-world hospital application. Different hospitals with different patients lead to different outcomes. But training AI to not have these biases is still possible and requires three big things. Transparency, meaning no more big black box of AI like we mentioned earlier. We need to understand where a decision comes from and how it was made. Second is diversity. We need diverse teams designing these tools. Teams of social scientists, doctors, ethicists, and engineers working together. And lastly, we need community engagement. Communities should be engaged in the process so that the AI is able to help the people it's serving and not leave anybody behind. The last ethical issue I'll talk about is harmful integration and country development. There are certain countries where they're not fully developed or incapable to handle AI, and one example is sub-Saharan Africa. AI has a huge potential to improve healthcare, but it won't have the same outcome everywhere. In the sub-Saharan Africa, introducing AI into health systems comes with some serious challenges. For one is infrastructure. To start, only 1% of the world's health data comes from Africa. This means AI models are trained mostly on data from other continents and might not understand local health realities, creating that data bias we talked about earlier. Paired with limited internet access and weak computing systems, running these tools is even tougher in this situation. As mentioned earlier, there's algorithm bias as well. Most AIs are trained on data from Western countries, and when you use those same systems in Africa, the results can be inaccurate and harmful. For a real-life example, a certain diabetic eye disease screening tool didn't work well in Zambia because it was trained on data from other populations, leading to multiple misdiagnoses. Then you have brain drain and finances, the money and brain power problem. Every year, about 20,000 healthcare professionals leave Africa. That shortage would only get worse if AI tools start taking these small jobs that are meant for nurses or doctors or aren't designated for local needs. On top of that, there's so little investment in AI that countries end up relying on foreign technologies that aren't tailored to their communities. Foreign influence on developing countries does not have the best track record historically. Lastly is global inequity in governance. Developed nations hold the most power in AI development, meaning African countries often have little say in the standards and rules of technologies. Without influence in the global discussion of medical AI and ethics, imported AI can be misaligned with local needs, exacerbating existing disparities. Next section is economics. One economic problem is the high cost. The high capital cost of AI is initially justified by a reduced hospital stay, but the more medical AI is used and the more positive public opinion is, the more hospital costs will increase. The increase of hospital costs will lead to an increase in insurance rates and an increase in taxes for Medicare and Medicaid citizens, just to offset the high medical AI costs. Additionally, is closed system versus open systems. Within orthopedic surgery, there are closed systems and open systems. Closed systems are ones like Mako, which only work with implants made by their parent company, while semi-closed systems like Navio rely on select partners. In contrast, open systems rely on no select partners and will work with any implants. This limits hospital choice and gives companies more control over pricing and availability. From an economic and ethical standpoint, it creates concern about market monopolies and restricted competition, and hospitals becoming dependent on specific brands rather than finding what's best for the patient. As can be seen, medical AI has a lot of room for improvement, but an equal amount of potential. On its current track, It'll soon augment clinician ability in scan analysis and data compilation as a tool to greatly improve efficiency, accuracy, and patient care. It'll result in a reduction of complications and recovery time with patients. Its advancements in robotic surgical applications with patient-specific planning and perioperative integration will result in an outcome and implementation-driven movement. Its epidemic prediction will keep society prepared and ready for future pandemics and keep mortality rates as low as possible. If the adjustments listed earlier in the economics and ethics section are implemented, medical AI will be used as a tool, not a replacement of physician and nurse capabilities, and it'll improve patient care and health systems worldwide. For the sources of all the information listed, please look to their works cited in the caption below. I hope this video has been useful in educating you and that you keep up with the current and emerging prospects of medical AI because they will be amazing. Thank you.